Okay, good afternoon, everyone. Thank you for coming to today's Scrutiny Board meeting. It's the Adults Health and Active Lifestyle Scrutiny Board on the 13th of February. My name's Andrew Scopes. I'm a councillor for the Beeston Holbert Ward and I'm the chair of this committee. Today we have some really important topics to talk about. They're sombre and serious, so I trust everyone will treat them that way. As usual, I would like to start by introductions going around the table. So I'll start going to my left. As I said already, I'm Councillor Andrew Scopes and I'm the chair of this committee. Thank you.
Good afternoon. I'm John Beale, former chair of Health Watch, still a board member of Health Watch and a co-opted member of this board.
Good afternoon, Councillor James Gibson, and I represent Crossgates and Wimore Ward.
Good afternoon, Councillor Taylor, and I represent Chapel Allerton Ward.
Good afternoon, my name's Ray Jones. I represent Horsforth and I'm substituting for Councillor Iqbal.
Good afternoon, Councillor Kevin Ritchie, Bramley and Stanley Ward.
Hello, Councillor Mahalia France, me representing Moortown and Meanwood Ward.
Hi everyone, Victoria Eaton, Director of Public Health at Leeds City Council.
Good afternoon, Caroline Barrier, Director for Adults and Health at the Council.
Good afternoon everyone, Dan Byrne, Health Improvement Principal for Drugs and Alcohol in the Public Health Team, Leeds City Council.
Good afternoon, I'm Magdalena Boo, I'm the Head of Public Health for Drugs, Alcohol and Safe Communities.
Hi everyone, I'm Anna First and I can't work the button. I'm a consultant in public health in Leeds City Council.
Hi everyone, I'm Andy Madison and I'm the Programme Manager for the Department of Health and Social Care with a lead for drugs and alcohol in the Yorkshire Number.
Good afternoon everyone, my name is Nick Rank. I'm the Assistant Director with Forward Leeds Drugs and Alcohol Community Service. Thank you.
And I'm Councillor Winkage, representing Morley South.
Councillor Conrad Hartbrook, representing Rothwell.
Good afternoon, everyone. I'm Councillor Caroline Anderson. I represent Adlin Wharfdale Ward.
Good afternoon. I'm Angela Brogden, the Principal Scrutiny Advisor.
Super. Welcome, everyone. Okay, so we'll go through the first few formal items. I'll hand over to Angela.
Thank you, Chair. So under item 1, there are no appeals against the refusal of inspection of documents. Under item 2, there are no items for exclusion. In relation to item 3, there are no late items. And under item 4, please may I ask if board members have any declarations of interest? And I shall take silence as none. Thank you. Under item 5, we've received apologies from Councillor Iqbal and Councillor Jones is attending as substitute member. Councillor Farley has also notified the chair that he may be late due to being at a licensing committee meeting. We also had apologies relayed from Councillor Venner as the executive member for Children's Social Care and Health Partnerships. Thank you.
Super, thank you very much. Okay, so moving on to the minutes of the last meeting, which is page 5 of your agenda pack. I'll take matters of accuracy. Does anyone want to raise any matters of accuracy? No. Okay, Angela, can you just run through matters arising?
Thank you, Chair. So in relation to minute number 69, further to the board's discussion regarding out-of-hours bereavement arrangements, we're just seeking responses with regard to registration services and the GP Confederation. So once we have those, then those will be shared with board members. In relation to minute 72, just confirmation that the Scrutiny Board's observations regarding the proposed budget proposals were incorporated into a composite report from Scrutiny, and this was shared with the Executive Board as part of its meeting on the 7th of February. Thank you.
Thank you very much. Just on that, so at our board, we got everyone on the board got to start of it before it was issued. I think we were a little bit ahead of other boards, so that's good. Extra consultation. Okay, so we're going to move on to our first substantive item, which is the Leeds Drug and Alcohol Strategy and Action Plan. So I'm going to hand over to officers to introduce it. I just, as always, I always say to everyone, you can assume we've read the paper, but obviously anything you want to draw out, feel free to. Thank you.
Councillor Arif was going to introduce the item, so I will just cover some points that she was going to mention. Just thank you for the opportunity to come to the Scrutiny Board to talk about the Drug and Alcohol Strategy and Action Plan. Just to set the scene, I think we just wanted to make the point that we are very well scrutinised on drugs and alcohol, nationally and locally, by the Office for Health Improvement and Disparities. So we've got a colleague from OHID today, the Joint Combating Drugs Unit, the Care Quality Commission, and locally through robust local governance arrangements through Councillor Arif as our executive member, Victoria Eaton as Director of Public Health. And we've got some good local governance arrangements through our local Combating Drugs Partnership, which was established recently with a refreshed membership, and a number of boards that report into the Combating Drugs Partnership. Councillor Arif, as you've arrived, do you want to take over or do you want me to keep going?
I can say a few words as well. I've got my notes here, but if you've done your part, I'm happy to come in. Yeah, sure, no problem. Chair, my apologies for being late. There was some highway maintenance on Clay Pit Lane. It's just slowed us down, so I'm really sorry. Councillor Haley is nodding her head. It's there, I promise you. So look, I'm really delighted to report to Scrutiny Board. To set the scene, we wanted to assure that the board we want to assure that the board that the drug and alcohol working Leeds is already exceptionally really well scrutinised by both regionally and nationally by the Office of Health Improvement and Disparities, the Joint Combating Drugs Unit, and the Care Quality Commission. And locally, through robust governance arrangements through myself as an exec member, as you've mentioned, and Victoria Eaton, our Director for Public Health, as a Senior Responsible Officer, the Leeds Drug and Alcohol Partnership Board, and other boards that this report reports into, such as the Leeds Health and Wellbeing Board, Safer Leeds Executive Children and People's Partnership, and of course this Scrutiny Board. Leeds has benefited from increased national funding, which is always really welcome. And this obviously comes with robust monitoring arrangements as well. The Home Office guidance to local delivery partnerships required a local board to oversee arrangements, which is the Leeds Drug and Alcohol Partnership Board, and a local drug strategy delivery plan. Leeds has already had a drug and alcohol strategy since 2000, which is the 2019-2024. And this was reviewed and redrafted by officers to meet a national deadline. Whilst we work at pace to meet grant conditions and deadlines, we are very aware of the need to take on the views of Leeds stakeholders. So we are taking this opportunity to review the strategy, which ends this year. We're taking the views from the Leeds Drug and Alcohol Partnership Board and its subgroups and this board, and we'll take the refreshed strategy and action plan through our governance arrangements. We're asking stakeholders today that what they think about this, what is contained in this draft and what is missing. So I'm looking forward to the conversation from the board. Thank you.
Thank you very much, Councillor Arif. Magdalena, do you want to introduce the report, please?
Thanks, Councillor Scopes. So we need a strategy that is fit for Leeds and which will identify and aim to address Leeds' strategic priorities, ambitions and vision for drugs and alcohol. But it must also be in line with From Harm to Hope. Now, I'm noting that 2024-5 is an election year, but also noting that From Harm to Hope is a 10-year strategy. So while there's a certain amount of future proofing needed, it's within the context of that being a 10-year strategy. Leeds' strategic priorities have been fairly consistent over the years. So those have been about preventing new people from being harmed by drugs and alcohol, harm reduction, and treatment and recovery from those already impacted by drug and alcohol harms. We've always had a crime and community safety focus, and we've always had a children, young people and families focus. And I hope that those are fairly uncontroversial priorities, and they have been our priorities through previous years. So we now have an opportunity to think about what's different in 2024 and whether anything's changed from previous iterations of the strategy. We've suggested, for example, that the framing of the problem may have changed. So in recent years, there's a stronger understanding of commercial determinants of health alongside social determinants of health. So, for example, we understand that alcohol is an industry which creates harms. And while we've traditionally focused on these harms at an individual behaviour level, we could focus on them at a citywide systems and industry level. A commercial determinants of health approach would, for example, focus on reducing exposure to alcohol through approaches to planning, licensing, advertising and sponsorship. From a social determinants point of view, we appreciate that where you live, your experiences and your influences have an impact on the risk of you developing a substance use problem. So evidence for risk and protective factors, for example, includes personal risk factors, parental factors, peers and other influences such as school connectedness and religious faith. So rather than individual behaviour prevention focus, the evidence suggests that a prevention focus could be at a broader local systems level. But those are just suggestions and ideas. Leeds is an inclusive recovery city, and this provides another opportunity and potential focus for the strategy. So recovery has always been in previous strategies alongside treatment. We could choose to give this a stronger focus. It's really important that there's broad consultation with stakeholders, including people directly affected by substance use, to get this right. And today is an opportunity to hear the views of this board. This is a journey. There'll be lots of hearing of people's views, and hopefully we'll get a strategy that's right for Leeds. Thank you.
Super, thank you very much. Andy, it'd be really helpful if you wanted to make any comments around how Leeds we fit into the system more widely, Yorkshire and Humber. If you have anything to say, thank you. Yeah, speaker, thank you.
Yeah. So I think it's probably worth noting, I think, to recognise as well, I think that Leeds is an exceptionally well led and developed area. I think nationally, the kind of commissioning and the service provision that you have in Leeds is recognised as good practice and is really strong. Often I'm kind of asked to provide contacts within the city to kind of talk to areas elsewhere, to talk about how well they're doing and how well led they are. In terms of the strategy and how it fits with the national strategy, it absolutely mirrors what we'd expect to see, the kind of strands that are often seen within those strategies. In terms of how they're performing well. There's always room for improvement, and I think you'd be surprised if you didn't hear me say that. There's certain elements where nationally where areas aren't doing so great. So one area particularly is opiate numbers in treatment. So that's one that nationally people are struggling to kind of hit the targets, and Leeds isn't any different there. But in terms of their delivery, their commission of the service, the way it's designed, etc., really well developed. So yeah, a lot of good things to say about Leeds.
Super, thank you very much. It's always helpful to get outside perspectives. I'm also going to give Nick a chance. I guess you work with Leeds City Council a lot, so good to hear your perspective on where we're at.
Certainly, yeah. Well, Forward Leeds, we're proud to be recognised as a CQC outstanding service, and through the AHAL investments over the past 3 years, we've put together a comprehensive plan to expand service delivery, and that's continued in 24-25, where we're planning to expand the treatment and enhancing the quality of service we deliver. We have a comprehensive approach for safer and healthier Leeds, which is aligned with the city's vision. We're a fully integrated service, so we are able to offer multiple services through the one door, so people don't have to travel around the city to get the support and help that they need. This year, 24-25, we're focusing on expanding our community-centred approach. We're looking at digital inclusion and recovery, and a specific focus on peer-focused recovery support. As I said, partnerships are a significant factor within Forward Leeds. We work in an integrated way with colleagues from across the city, offering a range of support. We have successful collaborations with multiple health providers, including Leeds Teaching Hospitals Trust. I suppose in summary, we're committed to providing a safe and effective treatment service aligned with the inclusive recovery cities movement. A significant part of our plan for 24-25 will be working alongside David Best and the community and the Recovery Cities programme. One of those aspects will be working within the universities and the university estates to offer drug and alcohol treatment support to the faculty and students that we maybe not reaching to our full capacity at this moment in time. Thanks.
Thank you very much. Okay, so I'm going to open up to questions from board members, and then we'll go from there if that's all right. So I'm going to bring in Councillor Gibson first.
Hi, and thank you for your report and for all the really important work that you do. And we know you all do a fantastic job. But I have a question. So around mentioned in the report, let me get the specific language. Commercial determinants of health. Now, I'm chair of the licensing committee for Leeds, and I want your opinion on the national legislation, so namely the Licensing Act 2003, and whether you think, what's your opinion on how that potentially undermines what you're trying to achieve with the commercial determinants of health? Because obviously the Licensing Act is permissive, and also within the Licensing Act, there is no provision as a licensing objective for public health, which means that actually when making decisions around whether or not to grant a license to sell alcohol, we are sort of hamstrung in that we can't take public health as a consideration. Now, Leeds has done some fantastic work with our cumulative impact areas, where we can make considerations based on the cumulative impact of alcohol in that particular area. But as for the rest of Leeds, it is difficult in that the licensing as a licensing authority, we may not wish to grant licenses based on public health considerations, but we're not actually legally allowed to do that. So what's your opinion on all of that, please?
Yeah, it's frustrating that health isn't a licensing objective. However, in Leeds, we've got a really robust process for supporting objections with public health data and information, and been very successful in having a number of licenses turned down. In fact, I've just seen an email. I think there's been 12 turned down over the last relatively short period of time. I think a series of months in particularly LS8 and 9. Councillor Irish is well aware of the process we've got. So I suppose would you say we're getting around it? We're doing our best with what we can do, and we're doing much better in lots of areas of the country. So we had the recent CMO visit and shared some of this information about the approach we've got in Leeds. And many of your colleagues on licensing committees have had our support in putting together these objections. So yes, we'd love it to be a licensing objective, but we do have a really good process in Leeds that is having some great impact. I think, Councillor, do you want to add something?
Yeah, thanks for that, Anna. That's a really good question, and a timely question. I think it's extremely frustrating, as Anna said, that it isn't a licensing objective. I mean, when we talk about wider determinants of healthy, what you're consuming in terms of if you've got 70% of the shops selling alcohol, which was the case in Hare Hills, as you said, we've done extremely well in that we've got the council has got a policy called the Community Impacts Assessment, and that's where our public health colleagues come in. And even though health isn't a licensing objective, it's the prevention of harm for children. And in an area like Hare Hills, where you've got a lot of young children, you're able to public health come in and present their evidence. And I think it was on page 18, if I'm not mistaken, my laptop switched off, where it talked about annually updating the data in terms of the alcohol and influencing licensing in that way. But in my view, it has to be a licensing objective. It's so very important. But I just want to thank colleagues. I think we've revoked in the last 12 weeks, we've revoked 8 licenses, and we've stopped, I think, 6 new licenses in the last 4 years since the IA. But we're having to rely and go around it when we shouldn't have to. So I think it's a really important question. It's frustrating. More needs to be done on this agenda, in my view.
Thank you. And I think that comment is really helpful in the fact that it should be there. In Holbeck, we've got a CIA as well. And the challenge is where areas where there's not necessarily as much reporting of crime as you might expect. We managed to use some data about hospital admissions recorded linked to alcohol misuse. And again, I think that's the team and the executive working constructively with what we have. But thanks for that, really. Do you have a follow-up, Councillor Gibson?
Not really, just to agree really that it needs national legislation. We are, as a licensing authority, we're sort of held back. We're doing everything we possibly can. As you said, with the cumulative impact areas in particular, those licenses have actually been reviewed. They're not new licenses, they're review licenses, because some of those premises were involved in things they shouldn't be, let's say, without getting into it. But yes, we need the national legislation. Simple as that.
Thank you. Victoria, did you want to come in?
Thank you, Chair. Just briefly on the question and point around addressing commercial determinants, as Magdalena set out, as well as the licensing conversation, which is really, really important. Just to flag that some of the other key areas that we will be keen to look at more, and this is part of a kind of a national, international movement as well, but just in terms of being very aware and mitigating as much as we can, and pushing back against the very proactive strategies of particularly the alcohol industry around misinformation of harm from alcohol, the resources that are created by the industry, for example, for education in schools around alcohol harm, which are created by industry, you know, with industry kind of interests in mind. So we've been doing some work to understand that more, and to play much more into that that sort of activity which is creating harm, particularly around the alcohol industry. So again, it's about prioritising that work, pushing back to industry much more than we previously have done, alongside everything else that we'll continue to do. Thank you.
Thank you very much for that, Victoria. Okay, I'm going to bring in Dr. John Beale next.
Thank you, Chair. I suppose this is not so much a question, but an observation, but members may wish to comment on it. I think it was very useful to look at the social determinants and then build on another group, the commercial determinants. But I see both of those as part of a much larger group, the wider determinants. And we've heard about the legislative determinants, and there are the taxation determinants. So there's a whole range of things which we actually need to bear, some of which we can directly address in Leeds. Others need government action in order to put the context that we might want to work with. So that's really just point one, that we need to look at that whole wider determinants, not just those that we've already mentioned. And secondly, it's always slightly puzzled me why we always put drugs and alcohol together. There clearly are some things which are common to both, but they are totally different in context. One is the use of illegal drugs. The other is a use of what you might call a legal drug, at least a legal substance to which people can become addicted. So addressing those, as I say, there are some things in common, so you can address both of them using the same techniques and the same information. The others, because they are different substances and different legislative arrangements and so on, need to be addressed specifically for drugs or for alcohol, not for both.
Thank you, Dr. John Beale. Do do you want to comment on that? Other than, so I guess we'll bring it into the conversation if someone brings something in. Andy, you want to comment?
I think, yeah, I think probably a kind of better use of the term would probably be substance misuse, wouldn't it? And it kind of encapsulates anything that kind of creates an issue with addiction or kind of dependence. So I think, yeah. Okay. Acknowledge.
Yeah, and I think the point you're making, Dr. Beale, is there's something around some of it. There's some kind of police enforcement stuff around availability of drugs, whereas alcohol, there's no, other than where you can buy it, we can all go to a pub and buy essentially as much as we want legally. Okay, so I'm going to move. I think that's a fair comment to be made and something that's worth consideration. Okay, I'm going to move on to Councillor Taylor.
Chair, I was going to ask the question that Dr. Bill just asked, but I'll just drop a bit in. I know you're doing a brilliant work and thanks for the report, but I would like to see more done in the deprived area. I know we talk about aerials and there was 8 refusal and 6 stop. What area were those? Were those in the deprived area? Because that's where most activity is, because there's nothing better to do with the private area. So it tends to drugs, alcohol, but every other shops is alcohol and drugs and vaping. What are you doing in the deprived area to slow it down?
Just specifically on the refusals of licenses, they were in LS 8 and 9. So we've prioritised action in those areas in terms of licence objections, and the cumulative impact policies obviously tend to be in those areas. So that there's a sort of framework there that our focus naturally, our attention is on in terms of licensing objectives. Did you want to talk about the work that in terms of the service, etc., and how it's focused in those areas, or?
Yeah,
maybe Nick does as well. Yeah. If you do.
Yeah.
Hi. Yeah, we're acutely aware of the need for our services to be in the places where they're needed most. That's part of the OHID investment this year. We're looking to expand into those areas of the greatest social and economic deprivation. We've got a robust community engagement strategy. So we anticipate seeing more of our staff, more of our recovery coordinators based in those areas that you mentioned, delivering the services that would otherwise be delivered within our units, of which we've got 4 across the city. So some much more outreach focus going forward.
I'm not picking at you at all, because I know you are doing absolutely brilliant job, but I'm just thinking back 2008, 9, 10, I sat in this chair when it was Dr. Cameron, and that's where he started with the smoking sensation. And I represent the private area, and it's still happening there. But, so I'm not saying you won't get it done, but there's a big but there.
There's one area of work that we've been doing for the last couple of years. Dan might want to come in on this. Is we've been fortunate enough through investment to procure a number of fibre scanners for the city. So we're working in collaboration with LTHT and GP surgeries to get those out and about and do liver scans for the residents of those areas. So again, they're not having to come into a unit to have a diagnosis. We link directly in with the hepatology team. Dan, is there anything you want to add on that?
Yeah, in addition to that project's grown. So we started with only a couple of machines. Now we've got several. And in addition, we now have a mobile unit, which is run from the hospital, which goes into different communities. But I think broader, and Nick's already alluded to this, is the significant investment we've received has also enabled us to increase not just work in communities, but outreach, and being able to go and have specific teams that look at specific populations and specific cohorts. And that's expanded across the 3 years that we've got funding. And the next year, the funding goes up significantly again. And we hope that we will be able to expand existing teams further, but also new teams, which we've put in our proposal. Thanks.
To remind you, we've got some brilliant third sectors who they are the heart of their community and who the community trust. So please think about our third sector who does reach the community. Thank you.
We're currently doing a piece of work to consult with third sector providers in the areas where we're needed, looking at spaces for us to operate from. So you might be hearing from us very soon.
Councillor Arif?
Thank you very much, Councillor Taylor. That's a really, really important question because, as you know, in similar areas to Hare Hills and Chapeltown, organised crime thrives in that area, and access to alcohol, drugs is so very common. I think the last point you made about third sector. So, as part of the CIA work that we're doing and the off-licence work, we worked with Touchstone to do some intense outreach work with vulnerable individuals to support them. So I think you're right, we've got to tackle this from every angle, and I think I'm really glad that this conversation is happening at the board to influence this policy in terms of working those communities and going to them. And I think that's really important because in deprived areas, there's so many complexities. So it's important that we've got third sectors that are trusted in that community that can work with those individuals. And obviously the police plays an important part in terms of the crime side of it as well.
Anna, do you want to comment?
Just one more quick point. I suppose just wanted to assure you that there's a really big step up in the funding this year, which you've hopefully seen in the paper. So you know, it's going to enable us to put a lot more resource into the areas you describe. And so I know, you know, absolutely.
Just you didn't have your microphone on, but I think we'll take your comment. I think it goes back to what actually Dr. Beale was talking about the wider determinants of health and what drives people to addiction and drug use or misuse. Okay, I'm going to move on to Councillor Ritchie.
Thanks, Chair. Excuse me. Thank you for the report. I think it's really thorough. I've not looked at previous reports. I know they're sort of summarised there. I don't know if they had the detail that you've got here, but it does look to have progressed through the years, which is welcome. And we recently had a briefing from Forward Leeds staff, and I found that really positive, really reassuring for us as members, how the great work you're doing, which is backed up by your outstanding rating, of course. Just a few points. I just wondered what your thoughts are on the sort of language around alcohol. So alcohol is a bigger cause of death than drugs. It's in the report, and admissions to hospital. And there's been a big focus around advertising, football shirts and what have you. But I just wondered if you thought, well, perhaps I'm leading you here, but I certainly think the language around alcohol needs to change. So how many people are in WhatsApp groups where it's wine o'clock and it's this and it's that, you know, and it's all taken as really trivial and it's a good thing to drink and what have you, and what impact that has on society and younger people who may come across that. I remember, I don't watch Coronation Street anymore, but they were always in the pub and they're always drinking, and when they're stressed, I need a whiskey, and it's that sort of thing. And if you agree, we have a responsibility around that. And then moving on to drug use, particularly cannabis use, and it's an issue that's concerned me for a while and wanting to understand more about the effects and the impacts. What I've noticed over the last 15 years, the stats seem to suggest there's been a reduction in drug use, but I think perhaps it's a shift in how it's used. So, for example, cannabis, I never got involved with it, but as a student, well, I wasn't really a student actually, but as a younger person, you associated with students after a night out, they'd have a spliff, this, that and the other. But now what I'm seeing in communities is people almost reliant on it day by day. They're walking around smoking cannabis, you know. So that shift, which concerns me, and we had a briefing on cannabis use, and I'm really grateful for the response that Magdalena and the team produced to me on some of my inquiries. But just to bring those to this scrutiny board and also link them to the strategy, one of the issues is around outcome 1 and 4.1 about the education and impacts of drugs, awareness, etc. And I noticed that the Advisory Council on Misuse of Drugs, ACMD, the acronym, have not updated the cannabis use since 2008, and it's now 2024. I think that's long overdue for an update. And I would have thought there's lots of evidence out there now from the countries or states in countries that have legalized cannabis to have more information about the impacts of the long-term use and so on and so forth. So I just wondered, I did notice in 2023 they'd reviewed the medicinal cannabis use, hadn't there? But nothing actually on cannabis. So perhaps a comment on that. And also on the medicinal use, access to those drugs, I think, is difficult through the NHS. And I expect there's a degree of self-medication. You make the link, cannabis medicine's good, cannabis will help my pain. So is there anything we can do to try and improve access to those medicinal versions, which are obviously safer and more controlled? And then another point I wanted to make, on page 38, there's a comment about prison use and having, let's find it, get the quote right. Continue use on an incentivized drug-free living wing in prison. That tells me that we've almost lost control in prisons, and it's endemic, it's used throughout, which is kind of quite worrying, really. So I'll leave it at that. And yeah, thank you very much.
I can make a start on some of those excellent questions, Councillor Ritchie. I think that you've asked some really searching questions. So I would absolutely agree that there are some social norms around alcohol, and we've already heard about alcohol referred to as a legal substance, and a legal substance we know causes significant harms. And I was just reading this morning a paper from America where they were discussing that most Americans don't realise alcohol causes cancer. In fact, some Americans think that alcohol prevents cancer. And yet the World Health Organization has told us that there is no safe amount of alcohol that we can consume in terms of our risk of developing cancer. So we remember, I think some of us remember when cigarette packaging didn't tell us that smoking caused cancer. And I imagine that our grandchildren, your great-grandchildren, will be surprised that there was a time when bottles of beer and bottles of wine didn't have the message, alcohol causes cancer. Alcohol directly causes 7 times the cancer. So you're absolutely right to call out our messaging and our social norms around alcohol. I think, unfortunately, as Victoria's already alluded to, the alcohol industry is very unkeen on some of the measures like minimum unit pricing and labelling, harms labelling. So I think kind of members in this room that maybe have some more kind of political and lobbying influence, that might be something to kind of consider. Cannabis, as you alluded to, we did prepare a report which was about cannabis in Leeds. And one of the things we very frequently heard from localities teams and communities teams was that people were using cannabis daily to self-medicate for conditions. And as I wrote in the report, that concerned me because cannabis isn't effective for a lot of conditions. It's only effective for a specific number of conditions for which prescription is available. But as you point out, the sort of doses and administration that people are using to self-medicate, they'll be taking in more tobacco often. They'll be causing more harm through self-medication. And that's not to hate on people who are genuinely trying to sort out their difficulties and their problems. So I think there's kind of an urgent need for us to try and help people with those difficulties and try to get them to proper sources of help for the conditions they're trying to self-medicate. And some of that's about GP access, some of that's about treatment services, talking to people about their long-term conditions and linking them in with kind of help for those so that they're properly helped. I won't talk about prison drug-free wings because I think Andy might be better placed to do so, if that's okay.
I think the issue about prescribing of cannabis for medical use has been raised before, and I just wonder whether Scrutiny might want to ask a medicines management expert to come and explain the process, because there is some guidelines on it, etc. So if that would be of interest, maybe that might be something you want to do. So obviously, it would be an NHS colleague.
Yeah, I think certainly getting a briefing note following up. So and if you could point Angela in the right direction, the report that Magdalena said previously, which was circulated around the whole board, and this meeting will be a suitable follow up. Okay, great. I'm going to let Andy come in next.
Yeah, thanks for that, Mo, for passing over that question. It's probably really quite difficult for me to answer as a politically neutral civil servant. But I think yes, I think you're right in highlighting that. And I think probably without kind of getting into the politics of it too much, it's something that's not an area that it has a particular influence over the running of a prison. But I think I suppose what that is doing is actually acknowledging the fact that there is a need for that in prison. And I suppose to ignore that would probably be remiss, really. And I think like you're saying, it's almost kind of telling a story that potentially we may have lost control over prisons. But I think to dismiss that and not acknowledge it and not provide help for those people in there would probably be a worse crime. But yeah, really difficult for me to answer that one, I'm afraid.
Thank you. Councillor Ritchie, do you have any follow-up?
Not really, Chair, but just to say, which I forgot, just linking in with the wider determinants, and it is covered in the reply that I had from Magdalena. I was concerned about the impact, particularly on children and families, and that is sort of recognised in the outcomes that sort of cannabis use in the house is having on people. But it's kind of been covered by Dr. Beale and the officers, so I'll leave it at that. Thank you.
Thank you very much for those questions, Councillor Ritchie. And again, it's interesting to go back to certainly when I was a child, smoking in the house was like cigarettes was normal. And there's a risk that we come full circle with cannabis. Okay, I'm going to bring in Councillor Anderson next.
Thank you, Chair. Can I just go back to the issue of the police that Councillor Arif raised? On page 37, outcome 3, there is quite a lot of reference to West Yorkshire Police and their involvement in this plan. So can I just ask you how often you meet with the police and what sort of relationship you have with them? Residents in my area report drug dealing quite often on streets. They know exactly what time of night it's taking place. They know the registration numbers of the cars, but the police go off in a different direction. They're not interested. Sometimes they even know the make of the car as well. So if they know the time of day, where it's taking place and the registration numbers, it doesn't take a lot of resource to just go and be at that point at that time. And it's just not happening. They're just not interested. So until we get that relationship right, we will never break these gangs.
Thanks, Councillor Anderson. I mean, I can speak about at a strategic level, and then I wonder if colleagues have got a better answer at an operational tactical level. So at a strategic level, we joined the West Yorkshire Combating Drugs Partnership, which is chaired by Alison Lowe, who's the Deputy Mayor for Policing and Crime. And we also are members of the Safer Leeds Executive, where West Yorkshire Police are represented, and the Reducing Reoffending Board acts as a subgroup to the Leeds drug. Well, they don't act as a subgroup. We would take issues to them. So, for example, we took this strategy to them, and West Yorkshire Police and Probation have had input into this strategy through that route. So, at a strategic level, I think we're very well joined up with West Yorkshire Police. At an operational level, at a neighbourhood kind of community level, I'm going to have to defer to other colleagues who might be closer to the ground. I don't know if Nick, you've got anything to add.
Hi, yeah. So we're increasing at Forward Leeds. We're increasingly linking in with the police in response to well, in relation to criminal justice objectives. So just to come back to Councillor Ritchie's point about prisons. So we work with the prison service and the probation service in terms of people that are released from prison. So our aspiration is to see as many of those people that do have a need enter treatment as quickly and as efficiently as possible. Also with the police, we're involved with them across multiple elements within our service delivery. So we have a criminal justice team. It's an evolving relationship, but one that's incredibly important. So although those relationships aren't maybe where we want them to be, they're certainly on that road to collaborating to provide an effective service.
It doesn't really sound very satisfactory, but this is what you would probably call low-level drug dealing, but that's where it all filters down to there. And until you get the people at the top, you're not going to stop the people at the bottom, but we still need to tackle it from the bottom up as well. So it's a shame we haven't anybody from the police here today. Actually, I know this is not a crime scrutiny board, it's a health scrutiny board, but all the same, they do feature quite heavily in the plan.
Yeah, thanks for that, Councillor Anderson. And it's certainly something I see in parts of my ward as well, where, to be fair, the police and the Leeds antisocial behaviour team work quite closely together, and they shut down houses. And I often think they're playing a bit of a game of whack-a-mole, because you shut one house and another one pops up. And I think there's that strategic piece, which is the county line stuff. And I always worry about the young people who get drawn into it on their electric bikes selling drugs. So I think if the board supports my suggestion, I think we should write as a board to the police and ask for some reassurances. And I saw your hand up. Do you want to come in? Any comments on that?
Yeah, Councillor Anderson, I was going to suggest that I contact Safer Leeds colleagues, if that'd be okay with your query.
Anything that you can do to help is much appreciated.
Yeah, and I think that's still there's something in writing to the police, recognising the challenges that we're seeing across the communities in Leeds. Yeah, Victoria, come in.
Just very briefly to add that the police do sit as partners on the Drug and Alcohol Partnership Board, so we will work with them through the board, and I'm very happy to take this conversation back to the board. So we can do all of those things, but just to reassure you, they are around the table at the board as well.
Thank you very much. Okay, I'm going to bring in Councillor Jones next.
I think I might be helpful with this. The police's strategy, as I'm told, is they're not after the kids on the bikes. They're after what's supplying them. And sometimes I'm made various complaints to the police about a particular piece, and they ended up with a major raid and with a major catch. And I think sometimes that's their strategy. Now, I don't particularly like that strategy, but I understand why they do it that way. But that's not my questions. So that's what's come to the police from when we've asked that question. I'm interested in two things particularly. One is the work that you're going to do in schools or doing in schools. How many schools have you actually got into? And have any schools actually said, no, we're not interested in this because this is a citywide problem? And there's the second question, which I've had some personal experience of dealing with ex-offenders who leave prison, went into prison with no addictions whatsoever, and actually came out of prison with addictions. So what is the connection between when they leave to be thrown out to do whatever, and then why the addiction that they have, what help is there for them, and are they directed as they come out of prison? And I think that's quite a serious problem. I directed a gentleman to you last week, actually, who was waited 5 weeks for an appointment. It wasn't particularly pleased by that, but has actually got some good help on that. But my concern is, what connection do we have? And does the actual prison service understand that when they're giving people things that are potentially addictive, that there is a longer term effect than after they've left prison?
Yeah, well, we have really good relationships with all the referring prisons in the region. We see a phenomenal amount of people referred to us from the prison service, whether that's Leeds or Wealdstone, wherever. And increasingly, we're targeted on making sure that those people come in, make it into treatment. So it's yeah. So Andy's just showing me the NDTMS, which is the National Drug Treatment Monitoring System data. So in Leeds, we're actually performing above the national average. I think is it 60% on a 3-month basis?
3-month basis, yeah, 57%.
With the national average at 40%. So, and as I said, being in the biggest county, we're taking referrals from all over, which complicates things. But as we can see from the NDTMS data, the performance is, the trend is going upwards. So we're getting better at supporting those people into the service.
And some really good news as well. Not Leeds specifically, but the Yorkshire Humber is now the second best performing region in the country on continuity of care from leaving prisons into drug treatment.
What was the first part of your question again? Oh, young people's. Yeah, schools.
Basically, a lot of the addictions may start at a fairly early age, with teenagers in particular. I'm interested in what work you're doing with that, to be honest.
Yeah, so we've got a really high performing young people's service within Forward Leeds. We are based in many schools. I can't give you exact numbers, but we do have a team of staff, and an increasing, an expanding team of young people's specific workers that go into schools. Through the AHAL investment this year, we've appointed, well, we will be appointing additional staff in to support that work that's already happening. That'll involve group and community workers. So again, it's getting into the schools, getting into the community areas, working with in a community assets based approach. So, and the performance in terms of young people leaving treatment successfully is again above the national average. So there is a definite commitment to young people.
Thank you. Will you be able to follow up on the number of schools that have been worked with and how many, if any, have said no to support?
I certainly will, yeah.
Do you have a follow up? No, thank you. Just it's interesting, maybe not just a comment, a link. I know a lot of third sectors are trying to talk about knife crime in schools. For example, the Leeds United Foundation is trying to go into most schools about knife crime, and it feels like there might be an actual link to see if we can work with third sector on that messaging and linking the two. I'm going to bring in Dan. You put your hand up.
Yeah, thank you, Chair. Go to address both of those issues. So the first one, the schools. So there's a multiple pronged attack with regard to schools. So Nick's already outlined that the Forward Leeds service have a really well established young persons team, and obviously the funding for next year we're going to grow that, and they work in schools. So that's one aspect. In addition, we have Safer Schools police officers who go into the schools as well, and also talk about drug and alcohol issues, particularly in relation to antisocial behaviour crime, the law, etc. And then on top of that, Leeds City Council also have a team that work with schools around various aspects of the curriculum, in which drugs and alcohol is also part of that. On the other aspect, which is the criminal justice side of things and prisons to communities. So continuity of care that's going from prisons to treatment services in the community, and also the other way around is a big focus for the national strategy, and that's reflected both in Leeds City Council across our teams, but also in collaboration with the treatment service and the prison, to raise the number of people who are coming out of prison who need drug and alcohol treatment, going into that treatment, and to remove many of the barriers that are there. In addition, we're looking to raise DRRs, which is drug rehabilitation requirements and alcohol treatment requirements. So that's people through the courts who can be given that option to go to the service and have treatment for those issues. And as has been mentioned, there is a big move generally in terms of criminal justice roles. Many more drug and alcohol workers who specialise in criminal justice, not just the Forward Leeds service, but our integrated offender management service, and those working directly with all of the other criminal justice agencies. So we're talking police custody, prison, courts and probation. Thank you, Chair.
Victoria.
Thank you, Chair. Just in relation to the point about schools, I think just to make a broader point, which hopefully is helpful, I think it's really good to have the comment and the question around what are we doing kind of upstream around prevention, and obviously the first part of the strategy is to reduce use in the first place. I think that the really important thing that I'd like to share with this board is that the additional money that we have received temporarily through the government is predominantly for treatment services, which is incredibly welcome, and we're doing some wonderful work in the city around treatment, but we want to stretch that as much as it's possible to use that more broadly around prevention and support, and the wider determinants you mentioned at the beginning, Councillor Scope. So there is a little bit of an art in doing that. We're making the point back to colleagues in OHID and broader that there's only so much that treatment of young people who are already harmed by substances is one thing, and it's very important, but we have to have more capacity to do much more work around skilling up young people to navigate this and preventing use in the first place. And that's the area that there isn't any explicit new funding around. We're having to create that as we go. So it's a really good point, but just to share with you, we're trying to be as flexible and move as much upstream as we can, but there are criteria around the funding that make that quite tricky at times. Thank you.
Thank you for that, Victoria. That's really helpful. Okay, I'm going to bring in Councillor Hartbrook next.
Thank you, Chair. I think Victoria may have partially answered the first bit. I've got one comment which leads into a question, and one fairly simple question. Reading through the report, there's a lot of really good outcomes and activities and things that are listed in there. One thing that struck me is, other than on page 29, where it talks about impacts on children, I personally felt there wasn't enough around the secondary victims of substance misuse. You know, the children, the parents, the partners, because the outcome for the individual who's addicted is one aspect, and there's a lot of really good stuff in here around treatment, but actually that whole thing around the wider societal impact, which actually can often be crueler and more devastating, because for one addict they can have an impact on multiple individuals. The next one was, again, feeding into the outcome. I'm very interested in terms of the individual stories or whether there are cohorts that are identified. So, for example, just calling out the young person who goes out on a night out and may not be addicted, but has an accident due to inebriation, is one type of harm from alcohol. Compare that with the poor guy that I saw lying outside Matalan last week, sort of completely comatose, clearly homeless, clearly drinking as a source of last respite, is a very different strategy to approach them, I would imagine, than, for example, a middle-class home drinker who pops into Tesco on the way home every night and takes something home with them, or like as was touched on by one of the other members, the routes and strategies where people coming into and out of prison or into and out of care homes have. So I personally would like to see more in terms of not the stories, but I don't know if it's where this leads into a question is it fair to cluster groupings of we are going to aim at this type of person, whether, and clearly there are differences from everyone's individual, but whether it's fair to make groupings and whether that would help make this what is a very, very thorough and very, very detailed list of actions be read in a way that is more, I see who you're trying to get at with this approach. So that's kind of where that leads into a question. And then the final question, which is a fairly simple one, is anecdotally, I hear that younger people are drinking less and it's less of a problem. I just wondered whether you could kind of comment in terms of the long-term trends in terms of alcohol use and how that's changing the work that's being done. Thank you.
Thank you for that really helpful question, Councillor Hartbrook. So I would tend to agree that you're right, that we need to have a stronger focus on what people often term affected others. So people who aren't using the substances themselves, but might be in the household, they might be colleagues of people who are using substances. So I would agree with that. And I know Councillor Arif and Caroline Barrier have asked us to take this to user and carer groups. So I hope that when we go to the carer groups, we'll be able to kind of add some kind of really rich detail and nuance about what that needs to look like and the strategy from the people who are directly affected. So thank you for that challenge. That's really helpful. On the second question, I think you are also right that there are different cohorts, there's different experiences of alcohol use, and that we might need to stratify those cohorts more. So just an example, we've got a role within Leeds Teaching Hospitals Trust who trains the workforce around identifying alcohol-related harms and using a test that's called Audit C, alcohol use disorders, 3-question test. So it's about, do you drink and how much do you drink on how many days? It gives you a numerical score, and that gives you an idea about whether that's likely to cause harms and be problematic, and therefore whether you're likely to need treatment. So that would pick up the young person who's fallen off their high heels typically and has got kind of cuts and bruises and hopefully not head injuries. It would pick up that person coming to A&E, but it would also pick up somebody who's maybe I've heard A&E staff refer to Sunday sippers, so kind of people who are lonely and drinking alone, and then they come to A&E maybe because that's triggered another health issue, but alcohol's the alcohol's the trigger for that. So again, A&E can pick up those people as well, and obviously the very vulnerable street cohorts. So although not all those people will end up at A&E, for those that do, I think that we've got a route to identifying those people experiencing harms and providing them with very brief advice and referral into treatment. And I think it's right to kind of stratify those. The data does tell us that drinking in young people is declining. I'm not in Leeds. I don't live in Leeds. I'm not in the communities, and I think I'd be really interested because the data is only one part of the story. I think be really interested to hear what elected members think about that and what they see in their communities and third sector organisations, because it's fine looking at a line coming down on a chart, but it's very different in your communities and what you're seeing. So I think we'd be really open to hearing about that. Thank you.
Thank you. And just briefly to add to what Magdalena's said, that even though it does look like the trend is changing with this younger generation to less drinking alcohol, and we do need to understand more about that and why and what they're potentially replacing it with. The drug related deaths are still going up. So that kind of work through to harm hasn't yet happened. And so we've seen an increase of about 25% of drug related deaths in the last couple of years. So again, it's kind of really keeping an eye on kind of prevalence and is that actually right? And therefore it's not working its way through to the data we see on either harm or death at the moment, which is obviously what we're very focused on. And in terms of patterns of groups of people as well, alcohol's always been an interesting one in its complexity of how it plays out across a city like Leeds. So really different to really different to smoking, for example, where, you know, the more deprived the community, the higher the prevalence. Whereas in alcohol, people from all communities tend to drink about the same, but the more harm is caused in our more deprived communities. So there's that relationship between, you know, patterns and type of drinking, not just level of alcohol consumed, which is really different across different communities. But I really welcome your points around getting to some of those individual stories so people can see how this relates to different people that we need to support. Thank you.
No, I was just going to jump in. I mean, clearly, as you've articulated, it's a very, very complex picture, and I think, you know, drinking and smoking are things that have, you know, that often take decades for the full effects of an addiction to materialize. I think I'm curious as to, you know, particularly with the younger people, because I know from, you know, I've got a 22-year-old and a 25-year-old, not speaking about them as particular, but talking about their peers and possibly them at times. I think there's a higher prevalence of people who don't drink at all. I think there's a higher prevalence of those who, I think what seems to have gone is more of the kind of continuous casual drinking. It tends to be more big nights out, so more impact when there is, so probably, you know, more accident related, more kind of, but it's a very interesting picture, and I think it's interesting as to, you know, if alcohol's going down, good, but if that just means that they're doing something else instead, then potentially it's, you know, the same or even worse. So I think it's very interesting to sort of to unpick that and just work out what the trends are, but also to work out actually what's the cause versus correlation of that. Thank you.
Thank you. And do you want to come in?
Yeah, just kind of reiterate and sort of drill down on some of the points Victoria made there about yes, you know, the kind of number of people that are particularly drinking is falling, and that is accelerating as well. So that the number of the people that aren't drinking accelerates, and it is more and more over years that have gone. But also as well, it's still the second highest rate of referrals is for alcohol in young people's drug and alcohol services. And what we're finding is that those who are drinking to higher levels and with more risk involved, and often comorbidities, mental health, also polydrug use as well. So they may be drinking less, but those who are drinking in a more problematic fashion, which I think speaks to what the kind of stuff you were saying there as well.
Okay, thank you very much for that. Okay, I'm going to move on to Councillor France-Mayer.
Hello, thank you for the report. I think some of the questions that I'm going to pose are possibly being answered in a roundabout way as well. I think one of the points that I want to make is regarding on page 34, you talk about developing targeted treatment for priority groups and vulnerable groups. I just want to say I have noticed for the last couple of years, Forward Leeds have been looking at the Muslim community, especially leading up to Ramadan. But I do think that needs to probably start a little bit early rather than the month before, probably 3 months before, to start raising awareness. But I'd like to know more about, you'd have, you know, a bit more detail, what you're doing basically to, what work you're doing with those groups, you know, what work you're doing with the local mosques, the temples and the local churches in getting into some of those hard to hit communities. And the second question I would like to ask is, on page 40, you talk about again, it's for Forward Leeds, vulnerable young people, and to receive targeted input and information from services. And I know, Victoria, you've mentioned about funding and capacity, which I completely understand. But my concern is we've got young people that are in our system, in our care system, and they're leaving the system and going into the world. But what interventions are in place to support those young people in the chaos of it all, really?
So within our 24-25 proposal to OHID, we have included a young person's care leaver coordinator. So that's a new area for us. So that's something that we've one at the minute, yeah. So that's something that we've identified as a need and an area for innovation for us. So they'll work obviously within the young person's team and work with those young people transitioning from the care home sector. In answer to your other question about working with communities, that is a current and ongoing piece of work that we're doing. So we've got the community engagement strategy. So where we're at currently with that is identifying, as I said earlier, in where we need to be, which communities where we don't have a presence in. We've got some work to do in terms of our service user population being representative of the city as a whole, which at the minute it isn't. So we recognise that we need to do that, and we need to get out to those places where we need to build trust and develop relationships with communities and with leaders, specifically with leaders within those communities. So part of that work will involve going to mosques, developing those relationships. We don't expect that that trust to happen to be developed overnight. That's something, a longer term strategy that we want to create, so that for whatever reason restricts people from contacting Forward Leeds and seeking help, that there's that trust there that they will approach us. Thanks.
Thank you. Do you have a follow-up, Councillor Farnsmere?
I'd probably like to see a little bit of that strategy, if it could be forwarded on, really. I'd like to have a look at that.
Yep, I'll forward that on.
Super, thank you very much, Nick. Okay, I'm going to bring in Councillor Kidger.
Quite a few points, actually. After Councillor Anderson said about the police, once a month we do our safety meeting with the police, and every month we bring up this about the where they're picking the drugs up, that the queue, and it's like a bus stop. And I agree with Councillor Anderson that I just don't think the police take it serious. We are asked to keep our eyes and ears open, but yet, and I've heard this from a PCSO, oh, well, they're not so bothered because at least they know where they are. Now, to me, that's wrong. So that's the first thing. So I do think we really could do with somebody from the police coming and talking to us. Going back to the liver, about the liver testing, we were approached in Morley to the town council by our community champion at Morrison's, and we had a van come into the car park in Morrison's the end of January, 26th of January. Now, I haven't heard any results as yet, but as far as I know, there was quite, if you can say, a buzz in town that people were going when they knew that it was free to go, and, you wait ages for a doctor's appointment. So I actually say that's great, and thank you for that. Going back to the drugs and alcohol, in Morley, I mean, we don't have a big problem, but back in the 80s, 90s, the serious drug people are now have gone into being alcoholics. Now, what we had in Morley was, at Morley Town Hall, we had regular, on a Monday night, a meeting, a bit like Alcoholics Anonymous or Drugs Anonymous, where people came together. Now, I can't think that that's happening now. And I wonder if anybody could check that up, because it was a regular thing on a Monday night at Morley Town Hall, and there was always quite a lot of people there. Started at 6 o'clock, went until maybe about 8 o'clock, and they purposely kept the town hall open, which I know cutbacks and what have you. But I'm just worried that in Morley, you know, we're not getting that service. So somebody could come back and let me know about that. And to be honest, you know, we're talking about all this drinking drug. I think our next problem is the vapes. And I think we really, really need to get a grip of that these vapes. You know, they're all saying, oh, they're safe and this and other. No, they're not. And, you know, there's so many business, particularly in Morley, that are selling them. And you can see youngsters, you know, I do invigilating at school, and they're always catching kids with the vapes, which at 12 and 13-year-old, 14-year-old is absolutely diabolical. But I do think that's going to be our next thing after the drugs, or as well as the drugs, should I say. And that's all I'm saying. Thank you.
Thank you, Councillor Kitchen. Just the vapes first. As you'll know, we did a piece of joint work with Councillor Cohen's Children's Families Board. So they are doing a piece of work on the vapes. So I think that's probably for their board, for the children's. They're hoping the government will ban single-use vapes, which will hopefully reduce children's uses. But I 100% agree with you. And it's just also on the police, I think your comments noted as well, I think goes back to, I think as a board, we do need to write to the police, but also the other comments made earlier around Victoria feeding back to the Health and Wellbeing Board. But Magdalena, do you want to come in as well?
Yes, so it's just a comment about the mutual aid meeting that met in Morley. I don't know specifically, and I can look, but public health, intelligence, working with Forward Leeds and others, we have created a map of mutual aid. So smart recovery groups, AA groups, NA groups, Al-Anon groups for families, Cocaine Anonymous groups. So we have produced that map, and I know that there is a commitment in terms of increasing the number of smart recovery groups as well in Leeds. So we'll get that map to you, and we can check where the nearest meetings are. We can't guarantee, because they're volunteer organised. They're kind of peers helping each other. But if anyone does want to set up a smart recovery group, we've got a link into Smart Recovery nationally. There's training available for people to set up smart recovery groups. There's a licence. There's lots of support. So we'd really support people who want to set up mutual aid. So yeah, we'll be in touch. Thank you.
Thank you very much. Just a question from me around, so on the last page of the report, it talks about key performance indicators, and I think you say that gets reported to the Health and Wellbeing Board. Would it be possible to share one of those reports with the Scrutiny Board so we can see sort of data you get and how it's being monitored? I'm seeing Magdalena nodding, so I'm taking that as a yes. Great. Okay, and I'm just going to bring in Councillor Ritchie.
Yeah, thank you. It's just on the mutual aid groups, and Councillor Ritchie makes a really good point. Just to say, I sponsor 4 rooms in the Civic Hall, Monday to Thursday or Friday, one day off, which is just an administrative thing. You know, I'm not trying to claim I'm a hero or anything. But that came about, each group does run as its own separate entity. And that came about, someone approached me about it. I met them, heard of what I'd never heard of them before. I'd heard of AA, but not NA. And it works really well. They've got through COVID and they're still meeting every year. They book the rooms. So I guess it is, as Magdalena says, down to an individual volunteer to want to set those groups. And just a nice footnote, every year they make a voluntary donation to the Lord Mayor's appeal in gratitude of using the room. So doing some great work.
Okay, good. I think we're coming to the end of that item. I can't see anyone else indicating, but just want to thank officers and guests for coming. I think it's been a really helpful conversation, and I do think it's worth just noting again about how you guys have been recognised sort of nationally for best practice, and so that's really positive, and it's good to be doing good work. So thank you very much for that, and obviously great work that Forward Leeds is also doing. So with that, I'm going to close this item. I'm just going to basically everyone who's a guest is changing around. So I'm going to have a 10-minute break while we change everyone. I'd really appreciate if everyone's in their seats by 3:05 at the latest, so we can start again all together. Thank you very much. Okay, welcome back. Can I draw everyone's attention back to this meeting in the room? Thank you very much. So for our second substantive item, item 8 on page 49, obviously a very important topic, but a very sensitive topic. But I think Karen's going to lead with a bit of intro about that. So I'll hand over to you. As I say to everyone, you can assume that we've read the papers. Do you want to comment first, Councillor Arif? Okay.
Yes, please, Chair. Thank you. So Leeds is committed to reducing the number of lives lost to suicide. Every death is tragic, leaving a lasting and devastating impact on families, friends, and whole communities. Factors leading to someone taking their own life are complex and are rarely down to one reason. This is why no one organisation is able to directly influence factors alone, and it's important we must continue to take a collaborative and system-wide approach. This is demonstrated by our strategic approach and the development and delivery of our action plan. It's great that we have representatives here from the third sector, Leeds ICB, to support the work that's being led by our public health team, and I thank them for their time today. We can never really mitigate the impact of broader policy or national or global incidents. Nevertheless, our action plan for the city aims to prevent suicides locally by targeting our resources in effective approaches that work. I will now hand over to Karen and the team to tell you a little bit more. Thank you.
Thanks, Councillor Arif, for that introduction. I just wanted to welcome the colleagues that are with me, so I'll let them introduce themselves, and then I'll just say a little bit by means of introduction. So Rachel, do you want to go first?
Yeah, thank you. Hi, everybody. I'm Rachel Buckley. I'm a health improvement principal in our public mental health team.
Hi, I'm Eddie Devine, Head of Pathway Integration for the Leeds office of the West Yorkshire ICB.
And hi, I'm Jules Stimpson. I'm from Leeds Mind, so a representative of the third sector.
I'm like Anna, I can't press a button, but it's obviously a habit in public health. I just wanted to say that talking about suicide can be really distressing and upsetting, because we don't know whether anyone in this room or anyone who's watching the webcast has been touched by suicide. So I just want to remind people at the outset, whether it's in person or people on the webcast, for anyone who's been affected or bereaved by suicide, I'm welcome for them to take any time out of this meeting and take time out. What I would say is Jules is here today on behalf of Leeds Mind. We are thankful in Leeds to have a suicide bereavement service, which people can access if they want to. That's peer-led, and they can access that by the website of Leeds Mind or by calling, and I'll give you the number, 0113 305 5800. Now, that's not a crisis helpline, but it's for anyone who's been bereaved or been touched by suicide. As I said, it's peer-led. So I just wanted to say that at the beginning. I wanted to start from the standpoint that suicide is preventable. And our strategy and action plan is really based on that. It's led by our strategic suicide prevention group, which has membership from across the city with a very wide range of organisations. But those organisations that have got the greatest potential to address suicide and make the greatest impact in helping to prevent suicides. There's council, there's NHS colleagues, there's people from third sector organisations, universities, police, transport, and obviously the Samaritans. But we do also have a broader network, which Jules currently chairs, which has a range of individuals and organisations, anyone who's interested in suicide prevention. So colleagues and those with lived experience have been affected by suicide have collaborated in this plan. It's not a plan that just us in public health have sat down and written. We've had a workshop and wider work around developing this broad plan. So the plan, just very briefly, is based on both national and local data. We also have local real-time surveillance data that we received from West Yorkshire Police. And we also did our Leeds suicide audit, which was for the years 2019 to 21. For ease, we've structured that strategy and action plan based on the national strategy that was launched in September last year. We know from published evidence many of the risk factors that might lead someone to take their own life. So in the briefing paper that you've already seen, and I am presuming that you've read it, it includes how we ensure we're targeting our work to prevent future deaths. There are a number of caveats, and Rachel would tell me off if I didn't raise that, about using data and evidence. And it's very difficult. It might seem like a small number, but what I really want to stress, I can't stress enough really, we must always remember that every number, every percentage we're talking about today is a person in Leeds who lost their life to suicide. So I would just like to remind members today about the importance of language when we talk about suicide. I think Councillor Scopes has already raised with you around the language guidance that we shared as an appendix. So I'll really just ask colleagues if they want to add anything, and then I'm happy for it to be opened up to questions. So thank you, Chair.
Thank you very much. Jules, do you want to give any comment in terms of third sector?
Sure, I can do. I guess just to say, though, I am representing Leeds Mind, one organisation, one third sector organisation, and in Leeds we have got a vast and big third sector So I am only representing Leeds Mind, but with that real sort of look to, we have got loads of other organisations doing great work, and as already mentioned in the previous item, that there are trusted organisations in different communities across Leeds as well. So it is about us all sort of joining together. And I think what's great about the network and the strategic group is that that collective voice is very much part of both of that and is very much part of the action plan.
Thank you. Do Eddie or Rachel want to make any comments? Eddie?
I'll just come in to say, because of course the funding and the programmes of the work we have in the NHS, particularly related to mental health, are very specific. But similarly, being part of the strategic group and the network, it really helps us to target the resources in terms of what we're genuinely understanding around where risk stratification is telling us that effort should be directed at. I think some of the learning that we're getting through some of the better data quality from the surveillance data is infinitely more helpful than it's previously been. And what we're not getting is the lag in data coming through that we previously had through national suicide, through NKISH, etc., which has been great and really helps us to think much more proactively about how we are targeting and pushing what our local priority should be.
Okay, thank you very much. So I'm going to open up to questions from members, and I'll start. I know, Karen, we talked a bit about the date in terms of ethnicity, in terms of whether we can, there's groups that we need to provide more support to. I just wondered if, and I thank you for the extra data in here about that. I guess just wanted to highlight it here because I think just want to get your take on if more data is needed, and would it be beneficial to you and your team if that was recorded?
Yeah, it would be very helpful. We're getting more and more data locally on our suspected surveillance data, but what we're still finding that when we do suicide audits of the coroner's records, the issue of a number of different things, including ethnicity, is still not being largely recorded. And I think that's a national issue. I don't think it's not just Leeds, it is a national issue. But really it's of great concern that protected characteristics are still not being recorded by coroner's records routinely. And I think we need to think about how we might escalate that issue. We raised it at our last suicide audit. We're raising it again in this suicide audit. And it is concerning that other organisations have to record it. Why aren't the coroners?
Thank you for that, Karen, and it's certainly something we've discussed as well as an exec member. It really does worry me that we're not recording the ethnicity. I'm looking to write a letter to the coroner. I wonder, I mean, if the board would be minded to do the same to put that pressure on. Really, I think it's just crucial to have that data because it helps in terms of how we respond as a service and what we do in terms of targeting.
Thank you very much. And yeah, I think unless members object, I'll be very supportive of that. And then the other question might be more for the ICB in terms of commissioning work. I note that on page 98 of the pack, the table shows that 165 deaths were mental health was a factor, and I guess that brings you to the question about mental health services in the city. And when I was reading the report, I also noted that there's a small, very tragic number of young people under 20 also in that group. And I was just wondering is there a big overlap in the young people? And I guess what work has been done to tackle mental health, I guess, young people and all age groups. Thank you.
So I suppose, as I pointed out earlier, there are a couple of big transformational programs that have come with targeted investment in terms of improving commissioned resources for people with more complex mental health needs. I think there's a number of things in terms of some of the work we've done through understanding some of the data. For example, we have a range of grants funding schemes trying to work differently with communities, because a lot of the challenges in terms of engaging with some population cohorts is the distrust that they have of statutory mental health services, the distrust that they have of the NHS in general, and the distrust of clinical services, really. Through part of our community transformation programme, we've invested to date, I think, £500,000 into grants funded schemes through grassroots community groups, through targeted work with communities in terms of identifying how we could support people in terms of that proactive early offer for intervention. The schemes that we've recently done have been targeted at, I think, young Black men, and targeted at where people are experiencing the real impacts of the cost of living crisis. So really paying attention to the wider determinant health issues and impacts also, where they've particularly have that intersectionality with sort of deprivation and the added complexity that comes with having a complex mental health need on top of that. All of this understanding is part of the way that we have developed and co-produced our response to improving our mental health provision through community transformation and crisis transformation. The work has all been done through engaging with people with lived experience and engaging with communities, particularly communities where we know we haven't had that reach in terms of statutory provision previously. And I suppose we're at the point of launching this new model of care that wraps around local communities rather than sits within sectors on a larger scale, which has always been the barrier, I think, between communities and mental health services per se. So we're starting to go live with that in 3 early implementer sites in April, which would be really positive. So these new models of care will work around local care partnerships with our VCSE partners, with primary care networks and with secondary care mental health services in a way that doesn't just silo someone's mental health need out with the wider determinant impacts that really drive good mental health and well-being, and addressing those needs not in silos. So that feels quite positive and quite a step forward. And all of that's been designed and developed and co-produced with the communities that we've worked with in terms of setting those up. The one last point I'll make is previously the statutory services have delivered a model of community mental health provision that isn't different no matter where you live. This new model of care will have an element of that that's the same in terms of the clinical care and what's the best evidence in terms of the interventions that are required. But it will also have that bespoke piece, which is the personalisation to local community needs that we've done in a really data-driven way to understand what the population needs are wrapped around each local care partnership, primary care network area, which is a huge shift from how we've done things previously. I hope that explains it. It didn't sound too waffly, but I suppose we're trying to get it to a population health focus that's generally risk stratifying where we should target the resources rather than looking at a citywide sector approach to driving mental health care.
And Chair, if I could just come in to add to that, that's about services when people are in those services. What I would also stress is the work that we're doing for around young people in terms of prevention. And I think one of the previous scrutinies we came and talked about the mental health strategy, which is all age, and the prevention aspect in priority 1. So it's thinking about that as well. It's not just about the services, it's about that prevention as well. And certainly we have a grants programme specifically focused for third sector organisations around suicide prevention, that very upstream work. So it's not just about the services, it's actually trying to think about that, the good mental health and well-being and that prevention agenda, which we invest in across the system as well. Rachel wanted to.
Thank you. Just wanted to come in that point as well. So the audit data that you're referring to, it's incredibly complex to capture some of that. We have a team that go into the coroner's office who read through toxicology reports, medical records, witness statements to then pick out where we think there was that mental health problem. So there'll be some of that 85% where it will be a witness statement or a relative saying they were suffering with their mental health. It doesn't necessarily mean they were at the Beckland Centre or they were receiving that service. So we need to always take that with caution. But I guess what it does do is it tells us that those people were suffering and do need some support. So the support through the services that Eddie talked about, the support through third sector grassroots organisations for people who are living, you know, in the community, they both need to come together to do that prevention element. Thanks.
Thank you very much. Just a little bit of pushback, Eddie. So I guess in terms of new way of working, I'd say at the moment there's long waiting lists for mental health service needs, and that wait is probably not always good for people. So I guess, do you believe that the new system will reduce waiting lists? And I guess the second question is around, you talked about a distrust of NHS and providers. I guess, do you do anything around commissioning around third sector providers where trust may be there already? Thank you.
Yes, in short. So if we look at the investment envelope across our community mental health transformation programme, I think we've had an additional £4.8 million come into the system over the last 3 years, and that will become recurrent. A significant proportion that I think we've invested. I'll have to come back to you with what the actual figure is, so I don't want to give something that's inaccurate, but a significant proportion of that has invested into bolstering our VCSE support and our support through, as I've described, the grants funding schemes that are the very, very early proactive interventions with grassroots community groups that we know that through our risk stratification that we find it difficult to reach in terms of statutory provision and access. I think the demands that we're seeing, we've seen a long tail of COVID recovery through mental health services, and we're seeing demand go through the roof. But what we're also seeing is demand for wider mental well-being and emotional distress and social crisis that isn't just diagnostically driven mental health intervention that needs medicine, that needs psychological support, blah, blah, blah. So it's wider than that. I think the whole concept of this different approach that focuses on not just, it's that very early upstream element of proactive intervention. Then there's the stuff around how you build the building blocks around communities that support people to maintain their wellness in terms of the wider determinants, then getting really, really quick access to intervention that's actually culturally appropriate, is going to meet your needs rather than trying to shoehorn you into something that isn't going to get you the outcomes that's required. and doing that in a way that targets our resources to best effect. If you're asking me whether we have enough money to deliver the mental health services in the way that it's just going to have no waiting list, I'd say no. I think this will be the bit that gets us to a different approach where not everything is a service offer. Something is a bit around how do we support people to maintain well in the communities? What is the relationship with people that we have in terms of expectation on services as well? And what is the actual service offer we need that's going to deliver outcomes rather than just hold the risk for people, should we say. So it's a different culture that we're trying to work within as well. All of this is being evaluated. We've got a current evaluation going on about the process of design and taking into the first year of delivery through niche. So it's an external evaluation we're doing across the whole of West Yorkshire. Each of the places has done very different models of how we're transforming our services. I'm sure we could quite happily share the evaluation data with you, because it's quite ambitious in terms of the cultural shift we're wanting.
Thank you very much for that. Okay, I'm going to bring in Councillor Kidger next.
Hi, this is very close to my heart because as a mother of a 29-year-old daughter who at 18-year-old down in Roehampton, down south, contemplated suicide after being bullied at university, and I couldn't get any help down there. I brought her back to Leeds, and the help she got locally from you guys was amazing. So I just really applaud you. And she's gone on to doing masters, and she's doing really well. So thank you from the bottom of my heart. The question I just want to ask you, I've done a lot of work with the marketplace, and I understand it might be closing. Am I right in saying that? The marketplace in Leeds, where young people can go and, we have a lot of experience in my area where they've gone for, mental health support. You don't know? No?
I think there's been something around re-looking at what the provision is, but I don't think we're at a point of discussing that at this point in time.
Right, it's just somebody told me, and my daughter had read it somewhere, and I was just really concerned because Leeds City Centre was so ideal for my area, and I know a lot of kids who have gone down and they've had some fantastic support.
I mean, certainly you can say that provision for young people in Leeds, the investment is the same as it has been previously. So there will be young people, there will be support for young people's mental health in Leeds going forwards, whether it's the marketplace or elsewhere. I think that's the point.
Thank you for that. That's makes me feel a little bit better. Thank you.
Thank you, Councillor Kidger. I'm going to bring in Dr. John Beale next.
Thank you, Chair. A number of years ago, Health Watch Leeds did a major survey of mental health services in the city. And one of the areas which it appeared was not being delivered particularly well was crisis services. Now, we haven't gone back and looked at detail, although there has very recently been a West Yorkshire-wide review of mental health services, which again has said crisis services aren't as good as we would like them to be. Bearing in mind that the most commonly recorded risk factor is a mental health history, and I take the point that the person may not have been in touch with mental health services. It may have been a family member, a friend who reported a history. And also bearing in mind that under living situation, by far and away the largest group are people who live alone. So I guess my question is, crisis services, as I understand it, are delivered, as it were, in a partnership between the Mental Health Trust, the Foundation Trust, the Leeds Community Trust, and the third sector working together. And part of crisis services are actually delivered by the third sector. So the question is, how is that working, that cooperation between those groups? and not only in terms of the actual crisis service itself, but actually trying to prevent getting to the need for a crisis service. And secondly, bearing in mind that living alone is also one of the factors, I wonder to what extent social prescribing by GP practices could play a role in supporting those people.
I think it's a really interesting question, Dr. Beale. I think we're in danger of sort of going into the whole debate around crisis services, which I think needs its own discussion. Eddie's going to, we'll come back. Yes, I acknowledge that we have crisis services both in NHS, but also in the third sector. But I just think, I feel we're in danger of kind of going sideways into services rather than thinking about what we've brought today, which is, you know, the whole issue around the suicide prevention strategy. So with respect, if we could perhaps park that one for now and think about this strategy. Thank you.
Don't mind coming back briefly because I think it's a valid question, really, and there has been work ongoing, particularly around how the various offers, because it's a big landscape of offers we have. We have a crisis house, we have children and young people's MindMate spa, we have a number of crisis cafes, and we have an integrated pathway with our statutory crisis provision with an overnight crisis house stay. And we're also looking about how that can support proactively people coming back from long stay out of area hospitals for complex emotional needs, particularly. So you asked the right question. People get confused around that plethora of resources and how it works and joins together. So it certainly is part of our community transformational work, is about how do we have that access that makes sense and how do we join it up so that people are knowing where they're going, and how do we understand that we're getting the outcomes from that, and what we're not just having is people bouncing around a multitude of services. Alongside that is how do you then join that with the proactive upstream offer I've described in terms of our approach for community mental health transformation. How do we have that connectivity together to make sure that is one access route? And there's a load of work that's happening behind the scenes for that also. And I acknowledge the point of it's still a confused landscape. People are still confused about access. We have a number of evaluation projects on the go at the moment. One that's being supported through some public health colleagues as well through our crisis cafes across West Yorkshire. And we need to pull all this together similarly for the same reason about how do we join this all up into something coherent. Got some great offers, they're just fragmented.
I can just come back on the primary care and social prescribing, if that's okay. So we have on our strategic suicide prevention group, we have a representative of primary care, and we're really keen to work with him to make sure we're working with GPs to encourage and support that suicide prevention is everybody's business, so that we're working with social prescribers, the primary care social prescribers, but also third sector social prescribers, so that they're confident, they're comfortable, they're compassionate in recognising where there may be concerns, issues, being aware of all the sort of variety of support. When I say crisis, I'm talking about somebody's sort of crisis around wider determinants, not necessarily a mental health crisis, but so that we can support them to identify, recognise, and then support people into those. So the primary care and social prescribing element of our plan is yet to be built, but we're really keen to work with GPs, work with people on the ground to understand what in addition we could be doing to increase that sort of professional curiosity, or whether we can look at flag-based systems. So that one's definitely going to be developed in 24-25.
Do you have a follow-up, Dr. Beale?
Just to say, I think the comments are very useful, and we maybe need to look at crisis care in the context of ongoing mental health care in more detail at some stage.
Thank you. I'll ask you to bring that up again in the next item when we're talking about our work schedule. Okay, I'm going to bring in Councillor Hartbrook.
Thank you, Chair. Two questions. I was really drawn to the table on page 90 around the deaths from suicide, comparison of gender counts, and reading again some of the other stuff that's in the really good report around the prevalence of suicide, you know, and the risk factors attributed to that. I was drawn, my eyes immediately went to the what seems like a drop in the number of male suicides from 83% down to 66%. But then just rereading the pack just now, actually it looks like what's happened is between 19 and 21 compared with the years before, numerically the number of female suicides has gone up. So I just wondered whether, I don't know what the answer is, but whether partly you could unpick if there's any stories or any learnings that can be shared from that. And then the other question that I've got is, I mean, sort of growing up in the sort of 70s and 80s, certainly amongst my older aunts and relatives, you know, the C word, cancer, was one of those words that just didn't get used in society. And I have a feeling that amongst probably many generations now, the S word, suicide, is one of those last perhaps taboos that doesn't get talked about enough in society. And I think it often comes at the end of a spectrum of other issues that people are experiencing. It's sadly, you know, what happens at the end of other processes. And I appreciate that this strategy is around that prevention at the end, rather than the more longer term societal stuff that may prevent people getting to that, I don't know, like 20-30% outcome tragic event. But I just wondered whether you could comment on, in terms of the taboos that still a risk exist around talking about suicide, and how we might challenge some of those.
So start with your first question first.
First one first. So yeah, in terms of the male-female split, so the data that you've referenced there in the audit was from 2019 to 2021, and you quite rightly pointed out we did see fewer male suicides within that period of time. I've just had a very quick look. I guess this highlights the importance of the real-time surveillance system that we have with West Yorkshire Police. So we receive a weekly email from West Yorkshire Police that tells us everything that sadly happened for Leeds residents the previous week. And it means that we can really be on the ball with directing and targeting our resources now, rather than relying on data from a couple of years ago. As of last week, we look at the last rolling 365 days, and we have seen that male rate go up again. And it does really highlight the importance of using that data and making sure we target our resources based on what we know from that audit, but we're also really up to date. I don't know if you're aware, but we also, since writing this report, we've also got access to the national real-time surveillance system as well, which means we can keep an eye on how Leeds sort of compares with national or other areas as well. That helps us sort of direct that work as well.
Answer the second question about
Second question about stigma. Really, so we share the language guide, really keen to ensure that people are comfortable and confident in raising the issue, in talking about it. We know talking about the issue, asking the question doesn't have that damaging effect that people worry that it might do. So we're really keen to make sure we support people to continue to talk about it. We're working alongside West Yorkshire ICB, who've got a campaign around checking in with your mate, which again is promoting asking those questions. And again, in terms of making suicide everybody's business, we really want to support people to access training, to become champions. We'd really welcome everybody today, if they're not already, becoming a suicide prevention champion. I think we included the link in the report. If not, we'd really value your support in doing that, and encouraging your communities and your colleagues to do that as well, so that we all see our place in challenging, in raising the issue and trying to tackle that stigma.
Okay, does anyone else have questions? Councillor Ritchie.
Thanks, Chair. I thought you'd already clocked me, actually. But never mind. So my first question was going to be how it links in with the community mental health transformation, and Eddie's covered that comprehensively. So thank you for that. Just one question on it. If somebody presents within the mental health system and they're not disclosing suicidal feelings, however, they're from a cohort which is in the highest triggers of potential suicidal death by suicides, would that be brought up as part of the sort of consultation? Would they be asked, I suppose, as part of the consultation, how are you feeling? Do you feel suicidal or suicidal thoughts? So that's the one question. The second question on the peer support bereavement groups, are they promoted at the point of a death by suicide to the wider family, but then are they also, because people might not be ready immediately, everyone's going to react differently to such a tragic event, would there be some kind of follow-up support and that ongoing care and offer to join those? And then the final point is on page 95 with the breakdown in the stats for the audit. I think it'd be helpful for context to have the percentages overall in the categories. So you do refer to ONS stats for carers, but what's the percentage ONS wise for unemployed and versus employed? It gives me a better understanding of which is obviously if there's more people employed, it follows that you might get more people from that cohort. But if there are only 2% of unemployed in the country, then that's quite a significant amount, that a fifth of the deaths are from unemployed people. So yeah, that's it. Thank you.
We'll go backwards on your questions. If Rachel could answer question 3, Jules question 2, and then Eddie question 1, is that okay? Thank you.
Thank you. I've not seen ONS report some of the suicide data against some of the sort of demographic data that you've talked about. I could be corrected, but I'm very happy to go back and see if they do provide that, because it would be helpful, like you say, if only 2% of the country are unemployed, yet we know that X% have taken their lives. So I will take that back to and try and unpick that more.
Yep, sure. In terms of the suicide bereavement service in Leeds, we're really lucky that there is a post within West Yorkshire Police who has direct contact with families after a death by suicide, and they provide the services information, and with their consent will give us the information of those families as well, so we can directly reach people in the real aftermath of a death by suicide. The service is open to people at any point, so any historical loss people are still eligible to be referred, and they can self-refer into the service at any point. So we do a lot of work in terms of outreach. So if we, thanks to the suspected, what was it, SSS data, thanks to that, we're able to do targeted promotion in specific areas of Leeds based on that information, and we continue to promote the service so that people know that anyone affected, and it is anyone affected, including people that have witnessed, found emergency services, anyone that's affected can refer themselves at any point after.
And we'll come to the bit around is the caveat that I don't work operationally within the provision, but I do understand what's commissioned and what's been designed through community transformation. So yes, is the short answer. All of the access would be through a helpful conversation. I think we're changing some of the language around assessments to a helpful conversation to help people identify what their presenting need is and what they wish out of the support that they access, rather than the clinical intervention. But that will be underpinned through an understanding of risk and an understanding of the factors that are presenting. Also, I think what's really shifting in the community transformation that's quite important is currently we move people around the mental health system based on risk. So if you're too risky for your access to a primary care mental health, you make a referral to your community mental health team, who will then do another assessment process and decide whether they're going to accept you against their criteria or not. And if it's too risky there, it then gets passed on in terms of the crisis provision or acute inpatient. This new model starts at the front door of your primary care network, local care partnership, and that's where your assessment starts, and it is layered by drawing in expertise around that same, so people aren't rejected, people are helped support access to the right expertise and the right level of support that they get. So that all has to be underpinned by risk, but it's risk in a different way through understanding how you then get the expertise that you need to address those needs, rather than using it as a currency to shift people around a system, which feels like a very nuanced shift in the way we better make use of our resources, but also better get people to the right help early doors.
Thank you, Chair. If I could make a general point, I guess, around the really clear understanding around history of contact with mental health services and the mental health problem noted, which is the 85%. I think it's incredibly important that we distinguish between that 85% figure that had noted a mental health problem, but often, as Rachel has said, it was a testimony of a family member or friend or whatever. In terms of contact with services, the 66%, 2/3 of people who took their own lives had no history at all of contact with mental health services. So 2/3 of people had absolutely no history of contact, and a third did, and that's really important that we understand that and get that right. But I guess it's that inevitable conversation we have around mental health services when we talk about suicide, when actually 2/3 of people have never had any contact, and before they took their own lives. And therefore, what we do as a city and a society outside mental health services will impact on reducing that 66%. It is a little bit confusing with the 85 figure, because that really stands out. But I just wanted to make that point, that actually, when we look at the people who are most at risk of taking their own lives, it's that the effort we can put into wider societal work to support particularly men who live on their own, and some of the other groups at risk around social support, as well as getting the mental health services stuff right. But it's just making that point about proportionality, really. So again, just to draw that to the board. And the other interesting angle, which again, when we loop round on these suicide audits, it's interesting in terms of services that often people who take their own lives are described as kind of hard to reach and kind of isolated. Whereas one of the interesting figures that always jumps out for me is the third of people who had actually accessed their GP in a month prior to the death. So they are presenting to primary care services much more than mental health services. And how do we work with all of our partners in the city to notice risk and intervene? So it was really just to kind of stress that point about the 66% with no history of contact with mental health services, and how we can keep the conversation as broad as possible around social support. Thank you.
Thank you, Victoria. And it's really helpful intervention. Just how do you think we can do that around helping, I guess, GPs, if they're the people who've seen, like medical professionals who've seen them most recently?
Well, I'm going to defer to my trusty colleagues here, because obviously there's a load of evidence around kind of what works in terms of interventions, and Rachel's point about suicide being everybody's business and people knowing what to look out for and what brief interventions would make the most difference and where to signpost to. I guess that's a good starting point, isn't it, Rachel? But I'll let you say a bit more.
Yeah, so similar to what I said before, that we've got somebody from primary care sitting on our strategic group, and we need them to tell us and lead and work with us, so we can share the evidence. Like we've said, we know how many people presented at primary care the week before their death, the month before the death, 3 months before the death. And we've also got sort of demographics and breakdown geographically as well of where those people were. So we're really keen to work with primary care colleagues to look at whether we can have flags on systems, whether we can encourage that professional curiosity, whether we can upskill and support those compassionate conversations, so that, like Eddie said, we're not assessing risk necessarily, but we're having those helpful conversations in primary care when people are turning up, so that we can identify if somebody does then need some further support, on whether that be social prescribing, whether that be a specialist service, whether that be a mental health problem, that needs medicating necessarily. That's what we need to do. So we're very much on with creating a plan with primary care and those support services to try and get that right. There's a couple of things in place already. So we want to go and talk to groups of GPs. We want to go and talk to social prescribers to understand how it feels, and to also share our data so that they can create those ideas, so that we can work with them and support that. Is there anything you want to add?
Thank you very much. And I guess that feeds into the action that's on page 68 of the pack, which is ensure tailored setting-based approaches taken to identify those at risk. Yeah, so it's good that it's on the action plan. Do you want to comment again, Victor?
Well, only just to make a really brief practical point that a lot of learning over the years has shown that those presentations at primary care before people sadly take their own lives, what's interesting is that they don't often present with a mental health presentation. They would come with something else, a physical problem, but obviously it's working with GPs to look for those signs when people present with a particular, there's evidence about people with long-term conditions or other physical health problems presenting with that, but actually being really high risk of suicide. So again, I think it's getting beyond the stereotype of somebody presenting with their mental health as in crisis before they take their life, but often they present in very different ways.
Yeah, thank you for that. And I guess GPs don't often have long with their patients, so I guess that makes it very, very challenging. Okay, thanks for that, Victoria. Councillor Alderson, do you come in next?
Thank you, Chair, and thank you for bringing this report today. It's it's a very interesting read and quite an eye opener. And also thank you, Chair, for circulating the document, the Creating Hope Through Language, because talking about suicide is something that I wouldn't naturally feel comfortable talking about, but reading this, it does help those discussions, and something that I'll certainly be promoting to people I know and constituents. The question I have is, I wonder if any of the members or visitors today have seen a campaign. I don't know if it was by Norwich City or featured Norwich City, but if I imagine, if I won't go into too much detail, because I think it would be interesting to see it. It's something that sticks in my mind, and it actually addresses something that Victoria mentioned there about how people may present differently. So the question I want to ask is, as a city, are we working with some of our region's largest sporting or recreational organisations who have a much bigger potential to reach these target audiences at quite, it's relatively easy. So I just wondered if there was something that we can be doing there. And as mentioned, I would recommend that everyone does search for that campaign, because it's quite a powerful one. Thank you.
So yeah, I've seen it. I think if I'm right, it's a football club, two men watching. Yeah. So it is a really, really powerful campaign. So I guess in answer to your question, yes, we're working with Leeds Rhinos. We've been working with them for a number of years, and they also sit on our network. They've also, and we've supported them to receive grants from us as well to do some of that real grassroots work themselves. We're also working alongside West Yorkshire ICB, who funded the Check In With Your Mate campaign, and we're looking to go to Sport Leeds Board and also to go to some of our bigger clubs separately to see if they can support some of that campaign work. Leeds Rhinos have been great. They've had, I think, information in matchday programmes on their boards, and we're really keen to continue that partnership with them to look at player testimonials so we can start to really get that conversation going. So yes, in answer to your question, but really keen for any opportunities to further develop that.
Can I just say something on that? We also work with other organisations like Rugby League Cares, who do training with other organisations as well, but from a rugby league focus. So sport is one of the main areas that we know kind of chimes with men particularly, but not solely. But yeah, so yeah, it's been part of our longer term work.
Thank you. And it's great to hear that you are already engaging in those conversations and looking to continue them. I guess the point, just to add to the point I was trying to make, is I think that by having an identity as a Leeds-based club or some in the region, it may just help target more local sort of people who are going through difficult times. All right, thank you. Appreciate it.
Thank you very much for that, Councillor Alderson. If you wanted to share a link around the group, that'd be appreciated. Okay, I think we're at the end of the conversation. I'd just like to thank you for coming today. Thank you for the report and the work that's been done, but also like a really detailed, and I think action plan which is time bound, and I think that's something that your report has stood out compared to a lot of the reports we get. Is very very precise. So, and the additional information I'd asked for at Chair's brief is in the paper as well, so that's all very appreciated. Yeah, so thank you for the work you're doing, and thanks for your time today. Okay, so that's the end of that item. You're free to go if you want to. We've just got the work programme now as members. As you'll see, we've got a meeting agenda for the March, which is the last meeting of the municipal year. But I'm very open to ideas for agenda items for the next municipal year, for the successor board, whoever. Obviously, we don't know who'll be on that board. I think we've had a comment already from Dr. Beale around crisis support services, and I think I'd welcome that as a topic. But if you don't think of it right now, feel free to email me at any point before May, I guess. That's when I'm still definitely chair for, so I can influence the agenda up until that point for sure. Do any members want to make any comments at this point, or is there anything that you want to say, Angela?
I think just what's reflected in the report as well, just to formally note that in view of time frame changes that have been made to the Community Health and Wellbeing Service pilot programme, the update report is now going to be scheduled for the Scrutiny Board's July meeting. So as the chair mentioned, at our next meeting, we'll be bringing along a proposed sort of draft work programme to pass on to the successor board. So that's one of the things that will be reflected on there, amongst other things which we can discuss at the next meeting.
Thank you. Councillor Hartbrook.
Just a thought on sequencing of the work programme for the following year. Obviously, we are in an election year at the moment. I'm just thinking perhaps some thoughts to some of the, some of the topics we've touched on today, touch on national government issues, to resolve them, such as, government strategy. So I just wonder whether we need to look at the sequencing so that the more purely Leeds based or purely, I'll say, administrative topics that we discuss, routine topics are discussed earlier, and then the more politically contentious topics are discussed later on, so that we know who we're targeting.
Yeah, I take that point. So if we want to write to a minister, we're writing to someone who's just started in post rather than someone who might be towards the end of their term, whoever that might be. Okay, Councillor Ritchie.
Yeah, thanks. In terms of future work programmes, and I've only had this year on this board, so it may have been done. But I think looking into the prevalence and patterns of asthma and respiratory illness, particularly in young children, I think would be useful to bring in it. I think it'd link in to the marmot around housing and what have you. It might end up being joint work with another scrutiny board as well, if depending on what the outcomes are.
Councillor Farley.
I think I say this for the past 2 years at least. Can we talk about workforce and where we're at? Obviously, we've spoken about it this year, but it never ends. Workforce and wider integration of NHS services, and then one for autumn would be winter planning.
Yes, thank you. I'd actually done a little bit of correspondence about workforce levels and level of bank staff being used across the NHS, the Leeds Teaching Hospital Trust. So maybe I should circulate that around the board. It hadn't sort of highlighted as a major problem, which is why I hadn't advanced it sort of as an item. But I'm definitely interested in workforce planning. I think it's really important, but I'll ask Angela to circulate some of the information I got this year. But let's keep it as on the radar. Winter planning is definitely something we did this year and we'll need to do every year. Yep. Okay, Councillor Alderson.
Thank you, Chair. On the crisis services agenda piece, could we potentially put some emphasis on those in our sort of authority border areas who maybe have a GP in one city but be a resident in the other, and how it's a point that I've raised before about the relationship, about sort of being batted over, you know, one side to the other, because essentially people in crisis need that assistance quickly. I'm not saying it has to focus all, but just be included on it. Thank you.
Yeah, thanks for that. And after your comment, when I've talked to Forward Leeds, I've asked that point about that transitional point. I think it's really interesting and challenging point, because the system, they call it system flow in NHS. It's difficult to do anyway, especially when you're moving cross-border, as it were. Thank you. And as I say, if something comes to you this week, please write to me, because if we can, I guess in terms of our role, I think it's particularly useful for us to get the first 2 or 3 meetings sort of lined up for the next board, but still leave space for them to have some options. Did you have another comment, Councillor?
Yeah, I was just thinking of topics that have come to me that have had a health angle, and I'm not sure if it is for this board. It's a bit like the vapes issue, where it's multi-systemic, but I think it's potentially one we should talk about. Is I've had a lot of contract around mold and damp in housing and the impact of that on people's health, both in council accommodation and in private rented. And it feels as though clearly there is a health angle there, so it feels as though something we should raise, even if from a monitoring perspective rather than a solutions perspective.
Yeah, thanks for that. Certainly something that comes into my inbox as a ward representative regularly in both council houses and private rented. I think we'll have to think about whether that's our board, but if it's not, I mean, I'm always up for writing to another board and asking them to look at something. Okay, good. Thank you very much for your time, everyone. Really appreciate it. I feel like we've had a really important meeting today, and so I hope you have a good rest of the day and see you next time. Thank you.